The pathology of rheumatologic disorders, there are three distinct characteristics: inflammation, autoimmunity, and degeneration. With inflammation, it's a complex process resulting in an abnormal growth of tissue in a joint, and it's called pannus. We have the patient will have an autoimmune component where the body recognizes its own tissue as foreign, and there is degeneration. This is secondary to that inflammation and growth of pannus in the joint. So rheumatoid arthritis, it can be chronic, systemic, and symmetrical. It is an autoimmune inflammatory disease. It primarily attacks peripheral joints, but it can also attack muscles, tendons, ligaments, and blood vessels. There is extra-articular involvement of organs such as skin, heart, lungs, and eyes. We will be giving prescribed medications that will probably be a combination therapy. So something to suppress the immune system, something for inflammation, and then something for pain. We have to be careful to administer foods or administer drugs with foods, but some are contraindicated to do that with. These patients will most likely be on a proton pump inhibitor, such as omeprazole, to minimize gastrointestinal adverse effects, especially if they're prescribed long-term NSAID therapy. If the patient is receiving methotrexate sodium, make sure that you administer folic acid to reduce toxicity. We will be screening and assessing the patient's pain. Pain treatment can include pharmacological and non-pharmacological interventions. Exercise can help preserve joint function, and they can also have surgeries to replace joints. Lupus, the body produces antibodies against components of its own cells, such as anti-nuclear antibodies. So their ANA will be high. They will have antibodies against almost any organ, tissue component, including the red blood cells, neutrophils, platelets, and lymphocytes. They will have microvascular inflammation, and it can occur in multiple body systems. So we're going to screen the patient's pain, auscultate heart and lung sounds for changes. We're going to obtain a 12-lead EKG if the patient experiences chest pain. We'll anticipate the need for continuous cardiac monitoring if the patient has cardiac involvement. We're going to provide a balanced diet with adequate fluid intake, and we're going to urge them to get plenty of rest because flares of lupus or exacerbations can be brought on by stress on the body. Human immune deficiency virus, or HIV. It is an acquired immune deficiency, whereas the first two that we spoke about were primary immune deficiencies. So this one is acquired because it's caused by a virus. And so despite our advances in treating it, it is still a public health issue that's important to pay attention to. Prevention, early detection, and ongoing treatment are important aspects for care. It is transmitted through blood and body products, seminal fluid, vaginal secretions, mother to child, but not through casual contact. So education on how to eliminate or reduce risk associated with HIV infections and AIDS is going to be how we prevent that. We're going to do behavioral interventions, HIV testing, and linkage to treatment and care. We need to make sure we are teaching how to use condoms. There's a chart on 36-4 in your Lippincott book. Also female condoms. We need to really focus on harm reduction framework for people who inject drugs like needle exchanges. They can use bleach to clean needles and syringes if they don't have access to a program. And we need to really enforce the importance of not sharing needles and syringes. So also reproductive education. We have to be very careful with artificial insemination, benefits of antiretroviral therapy, so it can actually inhibit that HIV or other viruses to multiply in the body. They can actually be given as prophylaxis in high-risk groups. Women who have HIV should refrain from breastfeeding. One of the high-risk groups is the LGBTQ group, and we need to really focus on youth in that group because they have the invincibility factor. They don't think about tomorrow, and they're very high risk for HIV infection. We need to remain non-judgmental in educating about prevention. To reduce the risk of transmission to healthcare providers, we should use standard precautions, hand hygiene, post-exposure prophylaxis. Antiretroviral medication should be given within 72 hours of exposure. You can expect to take 2 to 3 drugs, and they will be prescribed for 28 days, which is about the time it takes to convert and start replicating HIV in the body. This is the question. Antiretroviral medications as a post-exposure prophylaxis for healthcare providers should be started within blank hours of exposure. And the answer is 72. HIV pathophysiology. It is in the subfamily of the lentiviruses and is a retrovirus because it carries genetic material in the form of ribonucleic acid rather than DNA or deoxyribonucleic acid. HIV targets cells with CD4 positive receptors, which are expressed on the surface of the T lymphocytes, monocytes, dendritic cells, and brain microglia. So this will be affecting the immune system and the nervous system. So here are the steps in the life cycle of HIV. There's attachment and binding, uncoating, fusion, DNA synthesis, integration, transcription, translation, cleavage, and then budding. And budding is actually where there's replication of the HIV virus in the body. And this is what we measure when we measure viral load. So there is 5 stages, 0 through unknown. The stages 1, 2, and 3 are based on the CD4 positive T lymphocyte count. So stage 0 is early HIV infection, and it's inferred from laboratory testing. Nothing has really started happening yet. In stage 1, primary acute. This is the period from infection with HIV to the development of HIV-specific antibodies. There's going to be dramatic drops in the CD4 positive T cell counts, and it's normally 500 to 15,000 cells. Stage 2 occurs when T lymphocyte cells are between 200 and 499. In stage 3, their CD4 count drops below 200 cells in their blood, and they're considered to have AIDS for surveillance purposes. Unknown is no information on the CD4 T lymphocyte count or percentage. So when the assessment of our patients with HIV, most of them will be asymptomatic during the first stage or may exhibit fatigue or skin rash. Later stages have a variety of symptoms related to the immunosuppressed state. They usually will acquire respiratory manifestations like shortness of breath, dyspnea, cough, and chest pain. Pneumocystis pneumocystis pneumonia and mycobacterium, avium complex, and tuberculosis are very common in AIDS patients. Here is just a list of the HIV labs that you need to understand and what they do. There's also a pamphlet on the very last slide that will talk to you about the different tests and when they use them. So HIV symptoms can be vast and different for each individual patient. There are gastrointestinal manifestations like loss of appetite, nausea and vomiting, oral candidiasis, diarrhea, and wasting syndrome. There are oncological manifestations like Kaposi sarcoma, AIDS-related lymphomas. There are neurological manifestations like effects on cognition, motor function, attention, visual memory, visual spatial function, peripheral neuropathy, HIV encephalopathy, fungal infections of the nervous system, and one is called Cryptococcus neoformans, progressive multifocal leukoencephalopathy, depression, and apathy. They can also have integumentary manifestations like herpes zoster's infections, seborrheic dermatitis, gynecological manifestations like genital ulcers, persistent and recurrent vaginal candidiasis, pelvic inflammatory disease, and menstrual abnormalities. So the treatment of HIV and AIDS includes antiretroviral therapy. Its overreaching goal is to suppress HIV replication. So our goal is to reduce the HIV-associated morbidity and prolong the duration and quality of life, and to restore and preserve immunologic function. So what we want to do is maximally and durably suppress the plasma HIV viral load. So we're going to try to stop that replication process with medications, and we're also going to try to prevent further HIV transmission and do a lot of education and preventative care there. So we need to identify the potential risk factors for patients, what they might come in contact with as far as infection sources, and also their partners. Then we need to look at their physical status, psychological status, their immune system functioning, their nutritional status, respiratory status, neurologic status, fluid and electrolyte balance, knowledge level, and in elderly, most symptoms will mimic the signs of aging, so it can be very well hidden. So patients with HIV and AIDS will have these following nursing diagnoses. They will have diarrhea related to enteric pathogens, risk for infection related to immune deficiency, ineffective airway clearance related to the pneumocystic pneumonia, and increased bronchial secretions. They will have imbalanced nutrition, less than body requirements because of their consistent nausea and vomiting, deficient knowledge related to means of preventing HIV transmission, social isolation related to the stigma of the disease, withdrawal of support systems, isolation procedures, and then fear of infecting others. HIV collaborative problems and potential complications would include opportunistic infections, impaired breathing or respiratory failure, wasting syndrome, and fluid and electrolyte imbalance, and adverse effect of medications. We're going to talk about cancer. The rate of new cases of cancer is 442.4 per 100,000 men and women per year, and the cancer death rate is 158.3 per 100,000 men and women per year. What is the difference between a benign and a malignant tumor? A benign tumor is a normal cell growing in the wrong place at the wrong time or rate, and appearance resembles the parent cells in appearance, function, and characteristics. A malignant tumor is an abnormal cell that serves no purpose and are harmful to the normal body tissue. Appearance changes from the parent cells, and it loses the function of the normal parent cell. Also, benign tumors have a normal-looking nucleus. They have fibronectin, so cells adhere together. They do not divide when all surfaces of the cell are in contact with other cells. Where malignant tumors have large nuclei, there's no fibronectin, so cells adhere poorly and they're able to break off and migrate into the blood system. They continue to divide even when all surfaces of the cells are in contact with other cells. Malignant transformation is changing a cell with a normal appearance and function into a cell with malignant characteristics, and this involves 4 steps. Initiation is when a carcinogen enters the cell's nucleus and damages the DNA and genes. A carcinogen can be a chemical like alcohol and tobacco, a physical agent like the sun or chronic irritation, or viruses like Epstein-Barr and hepatitis. So they basically are inserting their own genetic material into the human cell DNA. Promotion, primary tumor grows over months to years. A detectable tumor is 1 centimeter with a billion cells. Progression, tumor agenesis factor is produced, and it stimulates capillaries and blood vessels in the area to grow new branches into the tumor. So the tumor has its own blood supply. It will continue to grow, and the cell characteristics change more and more. Malignant cells look totally different from the parent cell. Metastasis. The primary tumor the cells will break off due to the lack of fibronectin and travel to establish secondary tumors. The secondary tumor is still a cancer from the primary tumor tissue. Enzymes can open up areas of surrounding tissue or blood vessels, allowing the tumor cells to travel. So here are some classifications of cancer. Benign usually has the prefix MA, and the malignant has a prefix sarcoma, carcinoma, or blastoma. And so osteo would be bone, and osteoma is benign, and osteosarcoma is malignant. So those are some examples. 2 exceptions would be the lymph system, and lymphoma is malignant, and in skin, melanoma is malignant. Assessment of various cancers. We have colorectal. There's a change in bowel habits. They may have bloody stools. In the bladder, they may have hematuria. In the prostate, they might have hesitancy or change in urine stream, and pain in back and legs. In skin, they have a change in moles. In leukemia, they have fatigue and bruising. In lung, they have a cough and hemoptysis, or shortness of breath. Radiation therapy uses ionizing radiation to kill malignant cancer cells. They can cure localized cancers like thyroid, head and neck, and cervix. They can control when tumors cannot be removed, like the brain, or they can reduce the size of tumor prior to resection. Prophylactically, it can be done to prevent the spread to distant areas, and palliative to relieve symptoms of metastatic disease. Radiation therapy types. So teletherapy is an external beam. So the radiation source is outside the body. There will be some markers placed on the skin so that the beam knows where to go. These marks should not be removed by the patient. There's also limits of what type of product the patient can use on their skin, because some products, of course, we've learned are flammable, so they won't be able to use lotions or certain things on their skin prior to radiation. Brachytherapy are like seeds, beads, etc., and they're placed in the body cavities or orifice, example the prostate or vagina, and they are some of them are temporary and they stay in the body and then are removed. Some are permanent, and in breast cancer they have external for 6 weeks or internal for a few days. So they might have these placed in to reduce tumor size. So patient care with brachytherapy, we need to make sure they're in a private room with radiation warning sign. We'll wear a dosimeter badge. Visitors older than 16 years old, they need to stay only 30 minutes and 6 feet away. They can't have any pregnant healthcare providers or visitors. We will keep the tongs and the lead inside containers in the room. We'll continue the precautions at home, and we have to follow positioning and activity precautions. They have careful with elimination, so like their Foley. And for the ones who have like cervical cancers, we cannot even allow them to have a BM. They'll be on like Imodium to keep them from having BMs, because cleaning that up could also move the implants or require a care provider to be in the room for a long time. Seed implants can go home with minimal risks. And then systemic radioisotopes. This will be an IV administration of a therapeutic radioisotope targeting a specific organ like thyroid cancer. That'd be radioactive iodine. Chemotherapy. So anti-neoplastic drugs, they destroy cancer cells and prevent the spread of the disease. So they will damage the cell's DNA or destroy rapidly dividing cells by disrupting cell division and reproduction. They're good to treat systemic disease. They can be combined with surgery and radiation to reduce tumor size preoperatively. They can destroy any remaining cancer cells postoperatively. They require central line typically, and they require training, certification to administer. We need to watch for unintentional harm to normal cells, mucous membranes, GI, hair follicles, and bone marrow. This picture is of a port. It is surgically placed underneath the skin, and it goes into the subclavian vein. And it has a self-healing type of membrane on the top of it. We will be accessing it with a needle called a Huber needle, and it's actually in a straight 90-degree angle down. And we can use this for blood draws and chemo administration. The only thing you cannot put into this type of central line is TPA. It's too sticky and has too high of a glucose content, and it can cause increased infections and blockages. These are other central lines that are safe for chemotherapy, and here are some more. So we need to think about the nursing diagnoses common in care of patients with cancer, like death anxiety, acute anxiety, impaired comfort, chronic pain, infection risk, caregiver fatigue, and vomiting. They also will have psychosocial and spiritual needs, fear, altered health-seeking behavior, that would be like delaying of an appointment or not having follow-up, altered body image. Some cancers are disfiguring or scars can be left. They might have no hair. And then risky health behavior, and this would be drinking and using drugs and having poor coping. So chemotherapy basically stops fast replicating cells, and it can also damage the DNA in a cell. And it can cure, control, or be palliative. The patient must be realistic because this will determine the medications that are used and the aggressiveness of the treatment plan. There is a table in 15-7 that can help you review different types of cancer and chemotherapy. Leukemia, so the cancers of the cells that develop into white blood cells. Acute has a sudden onset and develops rapidly with a short duration. Chronic has a slow onset and progresses slowly over years. The non-functioning leukemic white blood cells invade the bone marrow, causing overcrowding and destruction. They also metastasize to the liver. It causes enlarged liver from rapidly producing white blood cells. And the spleen, it can cause an enlarged spleen from rapid proliferation. Lymph nodes and brain, it can also cause swelling in those areas. They're prone for infections. They will have problems developing functional white blood cells. They have anemia, so they'll have low red blood cells, and they will have bleeding, and because of the low platelet count. So labs, we will do white blood cell count prior to treatment, but the cells are immature and not functional, so they're still at risk for infection. The white cell count with treatment will go down due to bone marrow depression from chemotherapy, and they will continue to have that increased risk for infection. The red blood cells, we will be measuring in H&H. It's going to be low due to the overcrowding from leukemia and then from chemotherapy. And then activity intolerance, fatigue, and anemia. Platelets, they will have overcrowding from leukemia and then chemotherapy, so they have an increased risk for bleeding. To determine if a patient has leukemia, they do bone marrow aspiration and biopsy. So this will identify the blast cells from and the type of leukemia, whether it's lymphoid or myeloid. For the prep for this test, we will decrease anxiety by using guided imagery or anti-anxiety meds. The nurse or the family can stay with the patient. They're going to use a local anesthetic, usually lidocaine, and this is basically for the skin and the nerves around the iliac crest. They will expect heavy pressure with the needle insertion, and they will have a pulling or pressure type feeling with the aspiration. After the procedure, we will put pressure on the site for 5 to 15 minutes to watch for bleeding, and we'll be doing vital signs. It is more painful as the needle rotates in the bone. The iliac crest is the usual site, and the sternum is second. And bone marrow transplant is done for patients with leukemia to cure or to reduce their cancer. So a bone marrow transplant, the patient will receive aggressive chemotherapy to destroy the hematopoietic function of the patient's bone marrow. Then the patient is rescued with 500 to 1,000 ml donation of donor stem cells. They have to be accurately matched for the patient. After the transplant, watch for infection and bleeding until the transfused stem cells grow. So with a stem cell transplant or bone marrow transplant, The goal is to increase the patient's white blood cells. We're going to watch for graft versus host disease, and I have a website for you to look more into that on the last slide. Take the patient's temp, same as neutropenia. We will medicate them and stay ahead of the pain, and we are not going to allow them to have any fresh fruit or flowers in their room, as it may have germs that can infect them. Another topic I needed to talk about is heparin-induced thrombocytopenia. Patients can develop antibodies to form against the heparin and platelet complex when they're on heparin. So usually after patients are on the heparin therapy for 4+ days, this will happen. So what we'll do is watch platelet counts. We always want to review their admission platelet count. If there's a sudden drop of greater than 50% from their baseline, we're going to discontinue heparin and change anticoagulants, and they'll usually be on agatroban. Another cancer is Hodgkin's lymphoma. This is a cancer of the lymph system. However, it has a high cure rate. It has a viral etiology, so it is suspected that the patient would have a virus and then go on to develop this. There'll be an enlargement of one or more lymph nodes, usually on the side of the neck. It might be in your mediastinal area or around your xiphoid or your sternum. They are not painful, but they're firm but not hard. They will have Reed-Sternberg cells under the microscope, and they are usually treated with chemo and radiation. And on this page, I have several things that will help you better understand harder concepts. And that is the end of this presentation.